Thanks for this great chance. My case is 28 years old male presented to our department with the main complaint of abdominal pain and constipation. He had a 4-month history of intermittent, vague, non-specific, altered bowel habit, and intermittent rectal bleeding. There's no history of fever or rigor or weight loss. In the past year, he had experienced abdominal pain that would disappear after rest without any treatment. The precipitating factor for abdominal pain were food and stress. No other symptoms and no significant family history of genetic disorder or his antenatal history or no history of surgical intervention. By examination, the patient vitally stable and but appear anxious, and abdomen was lax and minimal tenderness, mainly on the left side, and by digital rectal examination, normal. Investigations normal except hemoglobin show no slight normocytic normochromic anemia with fecal calprotectin 212. And the patient initially had a CT scan of his abdomen and pelvis with normal, and barium enema was done and revealed also no abnormality, and this is the figures of CT. But the only comment is just acute angulation in between the sigmoid and the sternum, but normal. And the figure of barium enema also normal. So now we're facing the patient young age with elevated fecal calprotectin and altered bowel habit and abdominal pain. By colonoscopy, the decision was colonoscopy for elevated fecal calprotectin and no improvement of symptoms. هو في حال الفيديو كان مهم احنا facing the two lumens of colon and the biopsies were taken from both lumens. And the biopsies from both lumen was taken and revealed by pathological examination and both lumen are colons. and الاول كنا فكرنا ان هو ممكن يكون بيشنت عنده كرونز وعامل فيستولا مع سمول انتستين، لكن الحقيقه طلع ان التو ليومز كولون وفيهم اكتيف كولايتس. The patient discussed at my multidisciplinary team with surgeon and radiologist, and the decision was for follow-up colonoscopy and conservative treatment. And the rationale behind that, that the plan that the patient was not experienced any of complication associated with this condition, and the risk associated with operation more than the risk of duplicated colon. And the diagnosis was duplicated colon, and intra-abdominal duplication comprised 80% of the all GI malformation, and the most commonly occur in the ileum, and duplex colon can be cystic or tubular, but commonly cystic. And GI duplication generally diagnosed at early childhood and rarely reported in adult. And symptoms of duplicated colon varies from vague chronic features such as colic abdominal pain or changed bowel habit or obstruction. For diagnosis of duplication, CT or MRI, but a water-soluble contrast enema examination is considered potentially diagnostic. And the recommendation is the surgical intervention, but in adult there is no guideline for treatment of duplicated colon presented in adulthood. And thank you.